dedicated healthcare providers who are part of our executive council. And so a big thank you to all of you for helping us on this. We have a Padlet account that Caroline is always the wonderful one to show us how to use it. If anyone has any questions about it, please let us know. But on our Padlet site, you have overviews of what we have been doing. We have information about our upcoming webinars, different resources, and we do have a link to the Q&A Padlet account as well, where you can see some answers to family-centered care questions. We're continuing to grow, so we're up to over 340 listserv members in over 90 hospitals, and now are truly international. So we have centers in the US, the UK, Israel, Cambodia, and Canada at this point. And now it is my pleasure to be able to introduce our first speaker, Dr. Joy Browne. Dr. Browne is a clinical professor in the Department of Pediatrics, the University of Colorado Denver School of Medicine. She's a pediatric developmental psychologist, pediatric clinical nurse specialist, and is endorsed as an infant mental health mentor. She is director of Wonder Babies, including Babies and Pre-Steps program for early intervention professionals, and the Family and Infant Neurodevelopmental Education. She's a co-chair of the Graven's Conference on the Environment of Care for High-Risk Infants and Their Families, and chairs the Graven's Interprofessional Consensus Panel on IFCDC and Intensive Care. Dr. Browne's main field of research is in neurodevelopmentally supportive care and parent support. Please join me in welcoming her.
You're on mute, Joy.
Fatal flaw, huh? So it's so nice to see so many friends in the audience. I really appreciate your being with us today. And it's just a real pleasure to be a part of this effort. I really especially thank Malathi and Corby, but also Caroline, because I think she does a lot of the work to make sure that we're all organized. So thank you for allowing me to be with you today. What I will do in sharing my screen is make sure that everybody can see this. Is that all right with everybody? And I believe that the initial topic for this session was how to do developmentally supportive care. And I thought that for this particular group, it might be really interesting to be able to update you on some of the efforts that have been going on nationally and internationally in making sure that the developmentally supportive care that is done is evidence-based and that there is a solid foundation for work in this area. So aside from the disclosures, I'd like to give you a little bit of a historical perspective on developmentally supportive care. As early as the 1970s and early 80s, and I realize many of you weren't even around during the late 70s and early 80s, we started to understand that the support for babies in intensive care units not only included the ventilators, the medications, and so forth, but we also needed to understand the baby as an individual and how they communicated their needs. At that time, for those of you who were in intensive care units, the babies were typically not well supported. They were subject to not having a whole lot of nurturing human contact. And if you followed the quote unquote visitation policies over the years, parents were often excluded from the intensive care units. So since that time, there have been many, many different approaches. Some of the earliest work was done by Dr. Heidelise Alls and Stanley Graven, who were really interested in improving and enhancing not only the environments that babies grow up in, but also the developmental care for them, so that now we're in a totally different place. So during the period of time since then, numerous other perspectives have referred to their particular approaches as developmental care. And there's a wide variety of approaches that have been proposed, that have been studied, but don't necessarily incorporate the whole of how we refer to developmental care now. So as the evidence mounts for various components of what we see as developmental care, we also know that as a whole, it does promote better outcomes. That has led to international as well as national work to develop guidelines and standards for how we provide developmental care for babies and families, both in Europe with the EFCNI, which is a very strong family-centered care group, with professionals and parents in Canada. And I'd like to just fill you in on an interprofessional effort to develop infant and family-centered developmental care through getting together and as a consensus panel through the inspiration of Stan and Mavis Graven at the Graven's meeting to develop standards and competencies for developmental care in the NICUs. And interestingly enough, we have not limited it to NICUs. We have really tried to make it such that all intensive care unit professionals know what the standards are for infant and family-centered developmental care. I just want to show you a smattering of the people from different professions who have contributed to this really amazing work. And as you can see, there are several people who are on this call, as well as very strong parent representation. And we're really grateful that not only were they involved in the development of these standards and competencies, but also they have been consulting with us for about the last 6 or 7 years. We also have international consultants who don't necessarily work in the trenches with us to identify the competencies and standards, but they certainly have given us a perspective on other ways and other countries and how they implement developmentally supportive care. And they are implementing some of the ones that we have championed in this country. There are a variety of organizations that are represented on this panel, and we're hoping to add more as we are able to share the information about these standards and competencies. So when we talk about developmentally supportive care, we initially thought, oh, this is infant-centered. We need to know what the baby's saying, what the baby needs. And we recognize that that cannot happen without families involved and providing most of the effective developmental care for their babies. It focuses on growth and development, on holistic care. It has to be systems-oriented. It's interprofessional and collaborative. And it's actually all of those above things that we now define as infant and family-centered developmental care. Our model has a number of principles that we started out before we ever started looking at the literature. With the baby, the mother, or the other, as we call it, and that is that sometimes the principal caregiver for the baby could be a foster parent, it could be a father, it could be any number of people, but they are the center focus in establishing developmental care, that intimate relationship with the strong support, very close up of the father, partner, the significant other, the family. And then other of the principles are in what we have tried to orient everyone to and to integrate into all of the standards and competencies. And they include things like protection of the developing brain, infant mental health principles. The baby is a competent communicator and partner, and it can't happen without systems thinking in these really complex adaptive systems in which we work. So the rationale for really getting to the nitty-gritty of what's really out there in the evidence were a number of things, including that there wasn't a consistent developmental practice in intensive care, and everybody was interpreting things the way they thought it should be done. There was a lack of standardization among all the disciplines. Unfortunately, a variation of care and communication with parents and families. Parents were not originally considered integral to the health team. Parents were often confused, frustrated, depressed, and alone. And that's why this task force is so important to help support parents to be more advocates for better communication and knowledge bases. A lack of continuity from unit to unit and hospital to home, which is another big area that another group is focusing on. How do we prepare the families for the discharge home? And the lack of community resources to support the baby, parents, and family at home. So we decided to think about how do we develop standards based on evidence, which is the expectation of practice and the competencies or the behavior of practice. So in essence, these standards and competencies lead to how to do developmental care. So we started with those principles in mind as our guiding focus for all the work that we've done. We have searched over 1,000 articles. We have selected published articles within the past 10 years and those classic studies, determined the level of evidence, all of the meta-analyses, randomized controlled trials, and the majority of the developmental care were descriptive. So all of these articles were based on the strength of evidence and given a graded approach to what we decided we could really recommend as standards and competencies. We then got feedback based on our early work from about 250 parents and professionals on whether or not these seemed to make sense, if they were clear, if they seemed to represent the evidence. And we also had expert interprofessional reviewers to make sure that we were on the right track. When we looked at the literature, aside from comprehensive programs, we tried to break down what were the components that we could promote as evidence-based components of developmentally supportive care. One that is really front and center is the need for systems thinking in complex adaptive systems. As you all know, it's hard to introduce a construct or an approach into an entire system because of changes in management, changes in staff, changes in perspectives, pandemics. And so having systematic change is really important. And then the rest of these are areas that we felt there was a strong component of and contribution of evidence that would support standards and competencies in each of these particular areas. So the way we approached the integration of the parental perspective was we have integrated family-centered care into each of the standards and competencies. And I'll give you examples of that in just a minute. But one of the things that we wanted to do to give it a real parent perspective was we took the idea of Diane Moroney, who is a parent of a 25-weeker and has done a number of lovely publications on what it's like to be a parent of a baby in an intensive care unit, and use these imagines. And for example, one is imagine having one single event, your child's birth, be the cause for celebrating the best and the worst days of your life. So for each of our sections of standards, we have tried to emphasize the impact on the family members, in particular the parents. And I'd like to give you just a few samples of what the standards and competencies look like and how family-centered care is implemented into those standards and competencies. And it's mostly because we don't believe that you can deliver developmentally supportive care without incorporating the families into the care of the baby. So for example, the one on reducing pain and stress in newborns and families. And as an aside, I just shout out to Michael Heinen, who has been very instrumental in the development of this particular standard. So thank you, Michael. I think you're with us today. And this particular standard says that the interprofessional team shall document increased parental caregiver well-being and decreased emotional distress during the intensive care stay. Distress levels of baby siblings and extended family should also be considered. The competency, or where the rubber hits the road, is well-being and distress shall be evaluated within 72 hours of admission and 48 hours before discharge, as well as at other times indicated by clinical judgment. Now, there are a number of other things in these standards and competencies that are more specific to how to support babies during painful procedures, for example, but the basic idea that we're trying to get at is that it is not only the baby who is under stress and painful procedures, but it is also the family that endures a lot of stress during their hospitalization. A second one then happens to be skin-to-skin contact with intimate family members. And this one is kind of very straightforward. Parents shall be encouraged and supported in early, frequent, and prolonged skin-to-skin contact with their babies. So as a competency, first off, the parents shall be supported to recognize their baby's behavioral communications of stress and relaxation during skin-to-skin care. So just as an example, and there are a number of other competencies, but at least this gives all of these competencies, give hospitals a roadmap for saying, are we there? Are we kind of doing it? Do we have a systematic way of doing it? Or do we really need to start work on it? So another one is, and this one is one that I know you all are really concerned about because it is such a huge topic of interest, not only for parents and families, but also for professional staff. And there's so many ways of implementing the initiation and the continuing of feeding, eating, and nutrition delivery. So this one has many, many standards and competencies. But what really pops out to when you read these is that these shall be behavior-based and baby-led. Their principles are similar, whether they're applied to enteral, breast, or bottle feeding experiencing. And some of the competencies really stress the importance of families being able to be the first and most predominant feeders of their infant with their own preferences and desires for equipment, for feeding practices that are possible to implement. So once we got the standards articulated and integrated for both baby and family-centered developmental care, we thought, okay, now that's great that we have these. They are on the web. They are available to anybody who wants to access them. It's a roadmap for how to get started in implementation of developmentally supportive family-centered care. But we realized that there is a need for not only making sure that this information is available widely, that there are evidence-based standards and competencies, but also that we give them a toolkit for how to start implementing this in their own units. Often there is a small group of people who want to implement something on, for example, positioning. And that happens, and then it goes away with a change of management or a change in staffing. So we decided that we needed to really implement the process of not only developing the standards and publishing them, but also to make sure that those aspects, those principles of infant and family-centered developmental care are continually shown to be evidence-based and that they are available to professionals as well as parents. We also then realized that we needed implementation forums so that the people, the professionals in intensive care units would have a way of beginning to know how to get it integrated into the system. So here are some examples of publication and reference. And there are some of these that are going to be on the handouts that you will get from Carolyn. And there are a couple that are foundational to the standards. And then you can access the standards, competencies, and rationales, application, their materials on the website. So we're trying to get the word out that these are available so that people can begin to see what are the elements of infant and family-centered developmental care that need to be thought about, addressed, and implemented if at all possible. We also have a regular column in Neonatology Today, which reaches over 15,000 intensive care unit professionals. So every month we have a different article on any of those areas that we have identified as evidence-based or the principles. And so we would invite you to have a look at those. And we have just recently started forums. They are a white paper, and we have implemented the forums on each of the areas, but it also has developed a roadmap for how exactly to start to identify a problem that they want to work on, to identify all of the areas that contribute to it, and then to come up with a reasonable way of approaching it. So we've had our first one in 2022. 2023, we are getting together the panel participants so that they will be able to help others in other areas to address the systems implementation issues. And we're hoping to have another one in July and readdress the baby and stress and pain issues that we have identified as a real need for most NICUs to tackle. So, of course, there is a need for more research, study, and evidence improvement and dissemination. We are going to work with the forums to get professionals involved so that they know how to get started and really make it system-wide. We're going to continue to monitor the standards and the principles and practice in intensive care units from unit to unit. And then as we see new data coming available, we will be renewing, revising, and adding new evidence and new categories that we feel that there is evidence to support. We have all done this under the Gravens Conference umbrella. The Gravens is in its 36th year of work. They implemented the design standards that some of you may be aware of. And this is our opportunity to really come together as a group and share the new information about standards and competencies for infant and family-centered developmental care. We hope that the Family-Centered Care Task Force will join us at the Gravens Conference, which is March 8th through 11th in 2023, coming up soon. So hope to see a lot of you there. And if you need any more information, we would be more than happy to communicate with you and give you any kind of updates that we have. So thank you so much for your kind attention. I'm really looking forward to a conversation with everybody.
Thank you, Dr. Browne, so much for that talk. I am going to open it up to questions now. We have just a little under 10 minutes for some questions, and we had a couple in the chat that came through while you were talking. Jochen Prophet had asked whether when you mentioned you graded the evidence, whether you actually used the grade system or not.
Yes, we did. We used a well understood system for that. Our expert in that is Carol Yeager, and we did have most of those, and because of time, I deleted the slide for that, but there was a very significant grade system used for grading the information. I can get that for you if you are interested in it, Dr. Prophet.
We also had a question about plans for piloting specific sections in centers, and I would add to that about general kind of implementation and dissemination type plans moving forward. This is a great resource, and so it'd be wonderful to see it used in multiple centers.
Right now, we are hoping that hospitals will step forward and join us in the forums so that we know that they're working on them. And the more we know that hospitals are interested in working on those, we will collaborate with them to think about how we can evaluate them. Right now, our main focus is on updating the standards and conducting these forums on helping people know how to go about implementing. So it may be that in the next year or two, we will be able to have enough hospitals interested in any one section to have cross NICU collaborative efforts on evaluating where they are and where they want to go with that. We'd love to have anybody join us if you're interested, and that way we would know what different hospitals are working on different sections from this group. Colby, you wanted to know about. You're so right about it being a big culture and workflow shift in the NICU. The one that I know of that is evidence-based and it is really effective in changing the culture is the Sophie method that Erin Ross has implemented. And that one is really family-centered and baby-led, so that the work that she is doing and collecting more data on could be one that you might want to investigate. Colby, did you have any other questions about that?
I think honestly, it's kind of a question that goes with most of these standards that you're proposing. The baby-led kind of behavior-led feeding is prime on my mind, just because it's something we've been talking about in our unit recently and we know would be a major overhaul. But really all the things that you're mentioning are a pretty big culture change and are not simple changes to make, even though we know they're important, right? Because they impact so many of the different groups that are in our unit and impact so many workflows. So in general, I think processes to make these changes are helpful.
Absolutely. And, you know, because our first forum was focused on feeding, eating, and nutrition delivery, you might want to go to the white paper because it really addressed that particular issue and how different nurseries have and are working through that particular, how do you shift culture toward baby-led eating practices? And so the white paper might give you some ideas of how to go about that.
Absolutely. And we've got a pretty excited chat going on between a few of us here, because just the spoiler alert for the task force that we've mentioned before is our next phase is really hoping to focus on family-centered care benchmarking of metrics between centers. And so this is really exciting to already have these standards being thought about and created as we talk about ways to measure. I know Dr. Profit had made a comment, and I think Dr. Myers just echoed it as well, that the biggest issue is finding a way to have standardized measures that we can look at between centers, and this seems like a great step forward towards that.
Absolutely. And with the participation of Michael, and hopefully Malathi is joining our panel so that we will really have that emphasis even more than it is now, so that we can develop those strategies and those metrics with everybody's help, so that collaboration with this family-centered care task force would be really important, I think, in order to not only get the word out, but to establish some standardized metrics for looking at, are they implementing standards, whether they're just centered on family-centered care or whether they span all of these areas that we've identified as evidence-based infant and family-centered developmental care. That's a great idea to kind of merge the two ideas in establishing metrics for every one of our areas that we've looked at.
And Emily Whitesell just added in having a dashboard for developmental care, which would be great. So I think you've got quite a few interested people on this call alone to be working with you moving forward. We probably have time for one more question if anyone wants to have a last minute addition in before we move on to our next speaker. Any takers?
My email is at the end of the handouts that you'll get. Be more than happy to have anybody who's interested to get in touch, and let's see if we can't develop some real collaborative efforts. And
I put a link from your slides to the standards. I guess I'm going to take my own offer for a last question. Are the forums that you're planning open to anyone to join? I know you had the one in 2022. Are those open access for anyone? Yes, the one in July, whenever we get it established, like the task force, ours is all voluntary, and we're working as fast as we can to get these things lined up. And we really appreciate the support of Loma Linda Publishing Company, and PACLAC, which is helping us with all of the structure of putting these on and everything. But we're hoping to have another one in July, and I'm not sure of the topic, but it will be open to everybody. It would be really helpful if we could get the word out to you all to spread the word with your task force so that we can get as much input as possible. That would be really wonderful. So I'll keep in touch with it. Yes. I'll keep in touch with you guys. Wonderful. We'll definitely advertise it as we hear. Thanks so much, everybody. It's been a pleasure being with you. Thank you, Dr. Browne.
Thank you so much. I'm going to introduce our next speaker. Dr. Bobbi Pineda is an assistant professor in the Chan Division of Occupational Science and Occupational Therapy at the University of Southern California and Keck School of Medicine, Department of Pediatrics. Her research focuses on investigating factors that impact neurodevelopmental outcomes in high-risk infants, including how the role of parents shape the developmental trajectory. She is an author of a multisensory program, SENSE, which we're going to hear a lot about today, which was developed using current evidence as well as healthcare provider and parent input. Dr. Pineda also studies parent mental health, engagement in the NICU, early infant feeding, and neurobehavioral development, as well as factors that support or impede the outcome of high-risk infants. Her personal journey as a NICU parent, an occupational therapist, and a research scholar fuels her passion for improving infant care and maternal mental health. Welcome.
Thank you so much. Thank you for the opportunity to come and talk to this group. It's always hard to follow someone who's like Joy, who did such a great job, and I really appreciate all that she contributed to the conversation. Are you able to see my slides? Yes. Okay, perfect. Wonderful. Well, today I wanted to talk a little bit about occupational disruption, really, and then some programming that we have developed and implemented in order to be able to address this occupational disruption. And unfortunately, occupational disruption is very common in the neonatal intensive care unit. And what this means is that parents, as well as infants, are not really able to carry out the activities of daily living that are intended for them during that developmental period. And, these activities actually bring joy, and they also improve health. But one of the problems is that left unchecked, this can really make parents feel disempowered to be able to parent their child in the NICU, and then also can result in infants not having appropriate sensory exposures in order to improve brain development. And so, the definition for occupational disruption is a disruption to typical patterns of occupation, which could be due to environmental constraints or health conditions. And then this can lead to changes in their identity, routines, and participation. So I think we can all identify with this. And ultimately what it kind of leads us to really wanting to focus on is, the incidence of parental role alteration within the neonatal intensive care unit, the infant's environmental exposures and what we can do about that. And then also experiences that are going to lay the foundation for later development and occupations, and then really help parents be able to parent their infants during this critical time. So today I want to talk about programming that we've developed, the Supporting and Enhancing NICU Sensory Experiences program. And it's really intended to bring infants and parents together and help parents feel like they can participate and engage despite the medical interventions that are occurring around them. Our lab has also done some work really looking at parents within the NICU. Most of it was done in St. Louis, Missouri. It's a different population than what we have here in Los Angeles. But what we were able to identify is that a lot of our parents in St. Louis even have challenges in terms of visiting their babies or being present with their babies. So on average, that population, an average of 4 days per week is when our parents were there. So this leads to great opportunities for us to really change the story and allow these parents to feel confident and comfortable coming in and being parents. We also identified that there's a significant incidence of mental health challenges and then also low confidence. And parents with low socioeconomic status have more challenges in terms of participating in the NICU, for probably multifactorial. Can even be like reasons within the community, like needing to go back to work to save up days to be able to be off with their baby when they're discharged. It also could be related to having other siblings at home, but nonetheless, they have more challenges with participating. And then also, we were able to identify that parent engagement in the NICU is related to better infant outcomes. And so this is a really important area of research and also a really important area for clinicians to focus on, because the parents can be exceptionally powerful in changing the outlook for their infants. We also know that parents are the main drivers of their infant sensory experiences and their development. However, really focusing on trying to help parents requires intention. And so we set out to really try to identify programming that would bring infants and parents together in order to optimize outcomes, to help parents engage and really feeling like they can participate in their role as parent, and then optimizing the environment of the infant through interactions with the parents predominantly. Given the low rates of parents being present in the population in St. Louis, however, we also wanted to add additional factors in to help with the infant continuing to still really receive positive sensory exposures if the parents can't be present. And then, of course, we wanted this program to really be tailored and individualized for each infant. So not just going through the motions of programming, but really allowing the baby to lead the intervention, lead the sensory exposures, and then also giving parents choices in terms of what they can do, because not all sensory exposures are viewed the same across different individuals, different cultures, and so forth and so on. So the Supporting and Enhancing NICU Sensory Experiences was developed about 5 or 6 years ago now. It is evidence-based, and so the whole process of developing it started out with an integrative review, pulling together all the evidence from the last 20 years on specifically sensory exposures done with preterm infants in the NICU that led to improved outcomes at the infant level or at the parent level. We also then incorporated families in and shared where we were heading in terms of kind of protocolized program to get their input and insights and how they felt about the different sensory exposures that were coming from the evidence. We also were able to engage a multidisciplinary group actually at the Gravens conference a number of years ago, which included PTs, OTs, speech, nurses, physicians, parents, social workers. And then also did an additional one through the National Association of Neonatal Therapists, where it was largely therapist input that we were able to get. And this really helped us sort of ground on what typical practice is within the NICU and these sensory exposures, what challenges people were having in providing sensory exposures, and what would truly be feasible in terms of implementation. So the program also is designed to really define an amount and a type of sensory exposure based on the infant's postmenstrual age, realizing that the same sensory exposures are not appropriate for an infant at 24 weeks as they would be for an infant, for example, at 36 or ready to be discharged. And so all of the interventions or the exposures are kind of rooted in what normal sensory development is. Also, if the infant can tolerate it, and then behavioral cues that the infant gives that really drives whether you start or stop or pause the interventions as you go forward. And then again, they're intended to be parent delivered. And so the main part of the program is parent education materials. And I'll be sharing what those look like in just a minute. And then we designed it so that a sensory support team could fill in the gaps. And so when we did our randomized clinical trial in St. Louis, the whole goal was really to try to get to the parents as early as possible before they withdrew from the setting, and try and help them understand their important role and give them the tools to be able to engage and interact with their infant. But when the infants weren't able to come, we had occupational therapy students onboarded as a sensory support team to fill in those gaps. And it ended up being a pretty nice little dance, because most of the parents, even those that maybe we anticipated would not engage, actually did, which was really exciting. And then in some instances, even the parents were kind of like informing, okay, I have a doctor's appointment on Tuesday, I'm not going to be able to be there. And then the occupational therapy graduate students could come in to make sure the infant got positive sensory exposures when the mother knew that she couldn't be present. All of the activities are really intended to be incorporated into daily life within the NICU. So they're not really intended to be like above and beyond what they're already getting, but kind of this dance throughout the day. And typically the program is overseen by a neonatal therapist who does the education and then also assesses if the infant can tolerate it as it's defined or if adaptations are needed. And the reason why it's typically overseen by a neonatal therapist is that it fits pretty well with their role within the NICU. But I also have seen some physicians, some nurses, as well as other disciplines that have taken on that role of spearheading the sense administrator. So if you want to pull out your phones and see if this QR code works, you'll be able to pull it up on your phone. I'll give you just a minute to do that. And when you pull it up on your phone, it will ask for, I think it'll ask for you to check a box to accept the policies, and then there'll be a room for a password. And so the password is sense, so capital S and then ENSE and then exclamation mark. And I'll put it in the chat box just in case some of you are a little bit behind. And then once you open it up, you'll be able to see basically the written materials, which I'm going to show you slides of. And then also on the QR code version that pulls up the electronic one, there are embedded videos that explain with video descriptions a lot of the sensory interventions that are described within the programming. And so, for example, there is video on how to do a stand transfer for kangaroo care so that you decrease the amount of stress during the transfer itself. So check that out if you have a chance. And then I'm just going to show you a couple of excerpts from the education materials themselves. So this is the table of contents. And as you can see, there's a glossary of terms to orient the parents to different terms that are used throughout. Chapter 1 is about parenting in the NICU, what you can do for your baby. Chapter 2, experiencing the world. Chapter 3, growing up in the NICU and supporting the baby's senses. Chapter 4 is how your baby talks to you. And that's all about signs that babies will give that show that they're ready for interaction need a pause, or need a break. Chapter 5 is your time with your baby, when to interact. Chapter 6, helping your baby's senses, and the week-by-week sensory plan. And that's really the nuts and bolts of the program that tells you every day during a specific week of postmenstrual age, the types of sensory exposures that are evidence-based that you can do with your baby and choose from. And then chapter 7 is the how-to guide. And again, the printed materials, it's all in written form. But if you pull up the one on the QR code, it'll give you videos in that chapter 7 section that shows you how to do the things. And so chapter 1, and these are just a couple of little examples throughout the book, is parenting in the NICU. It really starts with establishing that the parents are the most important person in the baby's life, and really that we want them to be an active and engaged part of their infant's care. It talks about medical treatments that are going on around them, but that they can help their baby through different things that they do with positive sensory exposures. And then chapter 2 is about experiencing the world and the body's senses. So it breaks down the importance of sensory exposures, sensory input, and basically how that informs what we do in terms of motor, and is the building block of later function. It talks about sensory development and what's happening in the womb for hearing, and also all the other senses, seeing and tactile, and so forth and so on. Chapter 3 is about growing up in the NICU and supporting your baby's senses. And so it talks about the NICU experience and what's going on around the baby, and how different positive sensory exposures across these different senses can be really helpful to the baby. And then chapter 4 is watching the baby's signals. And so it talks about different signs that babies can give that show that they're ready to interact, that they're doing okay, or maybe coping with something that's going on in the environment. And then also signs that babies may give to show that they actually need a rest. And then chapter 5 is your time with your baby and when to interact. So it talks about the importance of sleep and the activities that you can do during baby's sleep, and also that could support sleep, as well as activities that you can do when the baby is about to wake up. And then the week-by-week sensory plan breaks everything down in terms of touch, hearing, smell, seeing, and movement and body awareness. And it goes week by week. So this one's for less than or equal to 23 weeks, and then it'll just continue to build all the way up to 40 plus weeks. You can see here under touch for a 23-weeker, it's to do kangaroo care or a hand hug with the baby for at least 1 hour per day. For hearing, it's engaging in quiet conversations near the bedside and during diaper changes. For smell, providing at least 3 hours per day of parent scent or the smell of breast milk. For seeing, protecting the baby from direct or bright light. And then for movement and body awareness, giving the baby opportunities for free movement for at least 2 minutes before a diaper change. And then also giving them the experience of being in different positions from a sensory perspective. There's a huge jump that happens at 32 weeks, where significant jump in terms of tactile, where you do at least 2 hours of positive touch. It can now include things like a hand hug, kangaroo care, holding your baby in a blanket, and then also doing massage as the baby's able to tolerate a little bit more at this age. For hearing, we'll actually have started to introduce hearing at this point by reading, singing, or speaking, playing soft music or recorded voices. We'll still do smell, and then for seeing, we'll have introduced cycled light, which is well established within the literature at 32 weeks. And then more opportunities for movement and body awareness, including rocking, in addition to the movement and position changes. And then by close to term equivalent age, you can see that there's even more. So at least 3 hours of touch, at least 3 hours of hearing, smell, cycled light with seeing, and then also having opportunities for direct interaction with a parent or a caregiver, and then opportunities for rocking, movement, and position changes as well. And then the how-to guide is going to basically just break down how you can do these things. So when you do massage, here's a way that you can do massage. Also follow the lead of your own team within your NICU, because they may have different ways of doing things. And again, there's videos that are available within the QR code or the electronic version. So far, about 400 or more hospitals have obtained the SENSE program and are working towards implementing it, including almost 30 hospitals within California that are part of the CPQCC NeoBrain initiative, which is really exciting. We found that parents and healthcare professionals have positive perceptions about the SENSE program through our research. It's also led to more parent engagement and in a lot of our high-risk populations, which is exciting to see as well. We've also been able to report in some of our recent publications that we've seen increases in parent confidence and then also better infant neurobehavioral outcomes. So our goal with the SENSE program is really to make sure it continues to remain current and updated, rooted in the current evidence. So we actually just did another integrative review and then made available SENSE 2 last summer as the second iteration of the SENSE program. And we hope to do this every 5 years again so that it's updated because new evidence continues to emerge all the time. We've also started training programs largely because there's been a large need or ask for them. So hospitals can participate as their own entity, really working on implementation strategies unique and individualized to them, or specific healthcare professionals can jump into other workshop type trainings that are done virtually. And then we're also just working on program accessibility through availability of this program as a not-for-profit entity. And so it will never be such that it's like a business endeavor, instead just rooted in trying to make it available to as many people throughout the world at whatever reduced cost we can possibly keep it at, just to maintain the infrastructure. And the ultimate goal is really to provide a structured format to aid parents in interacting with their infants in an age-appropriate and individualized manner while they're in the NICU. And that is all. I would be happy to take any questions that you might have.
We have a couple in the chat. At what stage of the NICU journey do you provide caregivers with the SENSE information? Is this something that hospital staff would reinforce from time to time throughout a NICU stay?
Yeah, that's a great question. So we did, when we did our randomized clinical trial, we enrolled 70 babies at St. Louis Children's Hospital that were randomized to either standard of care or the SENSE program. This was a structured research project, so maybe in more ideal format, we were able to get to the families fairly quickly. Sometimes even within 24 hours, and definitely by the 4th day of life, because I would say the majority of them were enrolled before the mother actually got discharged from the sister hospital, which was attached by bridge. And what we were able to find actually, and have now published, is that the earlier that the education occurred with the families, the more parent participation they had throughout their baby's NICU stay. So I guess my plug is as early as possible is best to really empower parents in understanding their role and what they can do for their infants and helping them understand the importance of them beyond just the medical team. And then how the program is set up is that there's at least weekly check-ins where you look at the baby's status, their tolerance of the program, and make any adaptations that are needed. And then also give the parents the next set of, okay, now your baby's 32 weeks and here's what we're going to do. And then also on infants who are in, say, a level 4 unit where there's more issues with acuity, those check-ins may need to be more frequent based on how sick the baby is.
Is there a way to adjust or modify the activities, someone asked, based on a change in clinical status or acuity, as you mentioned, or is it primarily based on gestational age?
So the program as it's written is just based on postmenstrual age, but within the implementation materials, there's strong suggestion to adapt it in context based on the infant's medical status. And then that can just be done on whatever bedside materials that you put at the bedside. So yes, there is encouragement to adapt them as are appropriate. But having said that, this was a level 4 NICU, 138 beds, acuity was fairly high. And we were able to find that 95% of the time, the program could be done just as it's written. There was 5% of the time where there were some adaptations that were needed to be done on a short term. But for the most part, it could be done as it's written.
That's really helpful. Yeah. I know you mentioned NICU therapists sort of taking on a leading role in this. Someone said, I imagine some of this content would be educational for nurses and physicians also. Is there an educational component to the program that targets staff to ensure that consistency across staff members?
Yeah, so I found like in the early days when it was first allowed for, when we first made it available to other places, most of the education was done at the hospital level. So whoever it was that was going to be the census administrator did their training and education with their own team. And that's kind of like how it spread. We do now have training programs that are available too, like if you wanted it to be more streamlined. And some hospitals have opted to like have a training just for them where they get their whole team together. And then you can kind of like problem solve and figure out what population you want to start with, how you're going to get it to spread, and then who's going to do what. And then also like implementation challenges can be anticipated and addressed kind of on the forefront.
How did you assess parent confidence?
Yeah, so parent confidence, we use standardized measures that were in the form of a questionnaire closer to discharge. So we largely use the infant care questionnaire and then the maternal confidence questionnaire.
Do you have plans to make it available in other languages, or is it already available in other languages?
What a good question. We're actually almost done with our Arabic translation. Actually, today I got the final little tidbits for the headers on that one. But it's currently available in Spanish and Hindi. And then Hebrew for Sense 2, we're in our final stages to get that one up and running. And then also Chinese and French are almost done in Sense 2 as well. So most of those languages that I just described are available in Sense 1, but now that we've revised it, we're just waiting for these final ones to come through. And then I think Korean is the next one on the docket, given a lot of our population in California.
This is just really exciting. So someone else asked, would this be something we could offer as a resource to parents regardless of what NICU they are in? I'm assuming maybe this is like that it's not just limited to one type or level of NICU or one state.
Oh yes, it can be implemented in really any NICU. I've stayed a little bit away of parents just being able to access the materials on their own, because I do feel pretty strongly that it needs to have some oversight at the NICU level, someone who can actually make sure it's safe for that baby. But yes, it can be implemented in a level 2, 3, or 4.
And I think we have time for just one more question. In terms of accessing this program, so you provided a link for people to get this glimpse into what the program can offer, specifically in English. What's the best way for people to get their hands on the program if they would like to implement it in their hospital?
I can pull up the link that takes you to the SENSE program. So it's through University of Southern California. I'll stick the link in the chat in just a bit.
Thank you so much. I really appreciate it, Dr. Pineda. Malati, I'll pass it to you.
Thank you. Thank you, Joy and Bobbi, for a wonderful presentation. We really enjoyed it. And it's my pleasure to introduce the next speaker and my mentor, Dr. Jochen Prophet, is a Chief Quality Officer at CPQCC and Professor of Pediatrics at Stanford University. His research, which has received federal and intramural support, and concentrates on measuring and improving the quality of neonatal and pediatric healthcare delivery, with a focus on enhancing organizational effectiveness. And Dr. Prophet has developed a composite indicator for quality of care provided to very low birth weight infants in the NICU called the Baby Monitor, which has been used to benchmark quality of care delivery in California NICUs. I believe he is going to share one of his slide with that Baby Monitor picture. In addition, its research has focused on organizational determinants of excellence, including patient safety, culture, eye reliability, and caregiver resilience. He is a member of the AAP section on perinatal pediatrics technical committee on neonatal quality improvement. And it's great to have you here, Dr. Prophet, and please take it away.
Thank you so much, Malathi. That was way too long an introduction. But so excited to be here. Thank you for having me, and wonderful work. It's just terrific to see this effort growing as it has been. So just so excited. Let me get to full screen mode. I hope you can all see this. This works well. Okay. All right. So talking a little bit about metrics and what we've been trying to do in California. Just some disclosure that part of this work's been funded by the NIH. Been very happy about this. Just wanted to, before we get into like the hardcore kind of metric part of this, I'm not going to make it that hardcore, but I just wanted to let you know a little bit about the California Perinatal Quality Care Collaborative. So we are like a statewide collaborative. Perinatal, we have a maternal side, we have a neonatal side. And we really try hard to find areas to work together. We have data sets that kind of reach beyond the NICU, but we do have about 140 NICUs. It's a big state, most populous state in the US. And we receive data on about 17,000. This is all annual babies that get sent to the NICU. There's about 500,000 births in the state. And so we also reach into kind of statewide data sets and link those to our clinical data sets from the NICU. So there's obviously a lot of babies that don't make it to the NICU, thank God. But we're able to know something about the mothers, we're able to know something about the babies during their birth hospitalization. We also track if babies are in the NICU. We do track transports, and there's about 7,000 of them. And then we also have a statewide high-risk infant follow-up program, which has about 9,000 visits a year. So large data sets are all linked together. And for any of you who's kind of interested in working with us, this is like an open invitation to come knock on our doors, because we don't want this data to just sit around, and we are frankly too busy to write it all up. But if any of you are interested in working with us, we'd love to do so. The kind of things we do through CPQCC are that we have this data set. We use it for audit and feedback. So we provide each NICU, and there's about 250 maternity hospitals. They're provided with kind of like their performance relative to their peers, and they can do this in a number of ways. We conduct quality improvement efforts similar to the Vermont-Oxford network. We offer sort of statewide improvement efforts. There's typically around 25 to 30 or so NICUs involved in a given effort. There's also some smaller group efforts, and the maternal side often does like whole statewide implementation parts, because they get a lot of pressure kind of like nationwide on maternal mortality and morbidity. We conduct a lot of education, webinars. We're an annual meeting in Coronado. If you're ever in the San Diego area, please join us in March. It's a terrific meeting. Bring your teams, and we'd hope to see you there. And then, as I said, we don't want the data to just sit around. Like, we feel like we have a responsibility to actually kind of publish the kind of things that we find, or when we work on implementation areas, to push them out to the general community. All right, this is just a brief idea like on what our one of the many reports on the websites look like. This is a dashboard. It's really conceived by the membership, so it's not just like us folks at CPQCC doing this, but we have a lot of participation from members in our community, and get about 100 volunteer hours a month, and our members decide kind of like what they want to see and how they want to see it. And so this is like an expression of the sort of bottom-up approach to quality improvement. All right, like there's not a lot of time, so I'm just making a quick, so it's just a bit of information about CPQCC now. Inequities in perinatal care, and I'm mentioning this because all work on family-centered care really is equity. care. And I'm just going to make the argument quickly to you why. So ideally, when we think about health disparities, there's sort of this big part of the social determinants of health, right? It's everything that my mom's experienced during pregnancy, and it's like homelessness and a lack of transportation, lower incomes, access to healthy foods, education, equal rights, ability to like live and play outdoors, etc. All of this influences the health of the mother, and then in turn the health of the baby. We've mostly focused kind of like what's happening here in the hospital once these babies come to the NICU. Are there inequities in how they're being cared for? And then ideally we'd want these sort of healthy babies come out of the NICU. But then we also need to think about like when families kind of go back into this environment, and Jeffrey Horbar really and Vermont Oxford have really been teaching us that we need to practice not just clinical medicine, but social medicine. So this is a sort of general framework on how we've been thinking about health disparities. And when we talk about this, and we like show people all the different ways in which health disparities occur, there's typically somebody in the audience who then gets very upset and tells us we treat everybody the same. So we actually asked folks, and there's some studies that clearly kind of show that's not true. And so here's some of our own dirty laundry from Stanford, where when we looked at when families don't speak English as their sort of primary language, we found that they do a lot less kangaroo care, about 50% of compared to the folks who do get to do kangaroo care if they do speak English. And this is adjusted for frequency of being at the bedside. So there's clearly sort of the barrier between staff providing opportunities there to folks who don't speak the language. Krista Sigurdsson was a postdoc with me, like this wonderful research on really stories that healthcare providers and families provided to us with regard to disparities that they had sort of experienced in their own lives. And most of these were stories that really happened within the last 6 months. There's over 300 of them, and I'd really encourage you to maybe look through the appendix of this article, which really kind of lists all these stories. Many of you as NICU providers will probably experience, as I experienced, that like most of these stories have happened in my own career. The point of this article was that there's a number of different ways in which disparate care can be applied, but really the main lesson here too was that the disparate care is usually not directed at the baby, but it's directed at the family. And so it's all about family-centered care, really, if we want to figure out how to reduce disparities at the bedside. So here are just a few examples of neglectful care. Just a general observation: when I worked as a charge nurse, nurses tended to just ignore parents who did not speak their language. Often the use of a translator didn't occur daily for educational updates. These parents would have to sit by the baby's bedside and wonder how they were doing. These parents did not get the opportunity to interact and bond with their baby as a result. And here's an example of judgmental care. I see this all the time. The way we treat Black moms is definitely different than how we treat white moms. Age plays a factor too. Young moms are judged very unfairly. One Black mom was judged very harshly for being late for a feeding, even though she had a long and challenging transit ride to get to the hospital. A white mother who was late on the same day was greeted with sympathy. So, these are just some examples. But again, like this is mostly directed not, I think, at the infants, which I think makes sense, but it's sort of how we treat the family. So what can we do? So first, at CPQCC, we do provide all of our NICUs now, and the high-risk infant follow-up program also is doing this now, opportunities to see results on key outcome metrics of neonatal care by race, ethnicity, and so they can find where they might have challenges, and they can look deeper and use this as a starting point for more investigation and change. We also figured out that since all of these pathways go through family-centered care, what can we do in order to measure family-centered care? And so we at CPQCC, we don't have direct access to the families. The data on the patients are kind of submitted to us in a de-identified manner by the hospital, so we never have any contact with the families. We could theoretically establish that, but it's kind of a big deal and difficult to do. And so we were wondering whether we could derive sort of proxy measures of family-centered care from data that's already in the electronic health record. And so we put together a panel that included family representatives. I saw that Lilis Vernon is on the call, and Ashley Randolph here. You can see is also one of our family representatives who've been helping with this work, where we put together about like over 20 measures and that could potentially be sort of indirectly seen as measures of family-centered care. And we went through a formal process of rating these measures. And then we also went to kind of families, minoritized family groups, and we asked them, and again, Ashley and Lilis did a lot of this work, and directly interviewed them about these measures and got their feedback. And so we went through like a number of rounds of ratings, and there's sort of it's like a formal process called a Delphi method, in which we kind of went through this and then looked at the results for each of these measures. And here you can kind of see all of the measures that we sort of had initially come up with. Actually, the families also contributed some measures that they thought were important, so we kind of added those. And out of all of these kind of, there's 6 domains and over 20 measures. Out of all of these, we kind of chose to start with 3. There were 4, like another one that is already being collected by the Vermont Oxford Network in their annual survey. And so we added this one, but this is already being collected. So days to first skin-to-skin care, hours to first classroom provision, and the days to first licensed social worker contact were the ones that the sort of group of experts had rated the most highly, and also kind of represented a bit of a spread across the different domains. There you go. That's what I just told you. And so we actually started a pilot program with units in California that were interested in participating in just measuring, checking whether these measures are relatively easy to extract and what the problems might be. And so there were 21 NICUs that started collecting this data in January 1st of 2021. And so we just kind of published this in an abstract, and we're kind of writing up the paper. But here's some of the data for you to see in the spread. So what we're looking for is this data feasible to collect, which by and large it was, there's some difficulty, but most of the places were able to do this, extract this data relatively simply. You may kind of wonder, like, why is it just days to the first? Why are we not measuring overall skincare, total days of skincare, total days of colostrum, et cetera, et cetera? The reason is it's just too burdensome for a data abstractor to get out of the electronic record. And so we were trying to, also think about the feasibility. Recognizing that it's not ideal. It's just, the idea like behind this is okay. Like if you're doing skincare earlier, that's maybe a signal of being more involved in providing skin-to-skin care, kangaroo care for families over time. And so, there are some assumptions there that we still will need to kind of address over time. But you can see quite a bit of spread. So you can see that the data is also somewhat skewed. So medians are probably better to look at. So, median days of skin-to-skin care, and these are small babies and larger babies, high acuity larger babies in our data sets, about 2.5 days. The first content, this is not just a positive touch, this is an actual hold. Social worker, this is a law in California, less than 2 days. Patients should be seen by a social worker in the NICU, and the hours of colostrum. But you can also see there's quite a bit of spread here, right? And I'll show you this in the next slides. So here, first, skin-to-skin care. So each of these is a NICU, and you can see there's like some NICUs here where this skin-to-skin care happens almost immediately, maybe with a few little outliers. But then there's some others where it's like significantly later. So, with this measure, this was the first social work contact, not quite as great in terms of spread. What we're looking for here is like, a good quality measure should have quite a bit of spread. If everybody's already doing the right thing, it's like why make you collect it, right? So here I'm a little bit, this is just 1 year of data. We'll check, now that 22 is gone, we'll update all this data and we'll see if we get more numbers if it changes. But if everything is that closely together, maybe that's not a good measure to pursue. And then here's the median hours of first colostrum. And again, you can see this is kind of a nice measure. Like there are some NICUs who are really doing excellent with like our colostrum like right away. Then not so like not such great results for some of the others, more like almost in like a 3 or 4 day range here. And again, this is like the median here. This is the interquartile range, and this is the like overall range. Well, does it mean if you're a NICU that does great skin-to-skin care, does it mean you do great oral colostrum care? The answer is no. So this is sorted based on skin-to-skin. Like this was the best performer, this is the worst performer, but you can see it's kind of like all over the place with regard to oral colostrum care. So the correlation is there's a bit of a correlation, but it's not strong. And so it's typical for what we've found anywhere almost in healthcare is that like if your NICU is great in one area, it doesn't necessarily mean that it's great in another. We looked at a number of different ways, since we're interested in health equity, to kind of think about sort of different types of NICUs and different types of patients. So we compared safety net NICUs versus non-safety net NICUs. And as you can see, maybe the safety net NICUs where it's just a bit more challenged with regard to oral colostrum and skin-to-skin care. Although I guess you could make an argument to me that I don't know how much it means if you're like, 8 hours later or a 0.7 day later. But ideally, you'd want to be, as quickly as possible. And then when we compared white versus non-white patients, similarly, kind of for these two measures, skin-to-skin oral colostrum, sort of a negative direction for non-white patients. I'll show you what this looks like. So Beate Danielson was like our statistician and sort of web designer, like in her typical manner, within like 3 days, like developed like this amazing dashboard for folks that are interested, like that are participating in this pilot. And so this is our family center focus board. And when you get onto it, you can kind of see how you're performing with regard to your oral colostrum. So all of these patients in this particular NICU got their colostrum, and they got it super early. This is sort of the general range in the group, and this group really did like an amazing job here. Also, skin-to-skin care, doing a good job here, less than 2 days. But interestingly, this unit though was somewhat challenged with social workers, which took them sort of 4 days to get to. So interesting finding. They can look further, and they can really look into all kinds of little details for their results. So they can hear. So these are the process outcomes that we have for them, and they can look at this is skin to skin, but they could pull up a similar one for oral colostrum, and they can say like, okay, we want babies with congenital anomalies or not, or whether they are on high frequency or not, ventilation, or whether they're like inborns and outborns, or whether they only want to look at like the small babies. So there's ways for them to look at the data in different ways, and they can kind of see if, like, for what kind of subgroup of patients are they performing well, and kind of similar down here. So yeah, these are the different panels that they can look at. And then here, I thought it's kind of interesting again, since we kind of showed this for the overall group, just in this individual NICU, you could kind of see that, like, okay, median skin to skin, this is like, so like these box plots here is the entire group, and then the star is like where this individual NICU is performing. So this NICU, which is a different NICU from the one that I just showed you before, because I want to keep things blinded and confidential to folks. But this group, is doing a bit better here on skin to skin care for white babies, and they are for Hispanics, and they are for Black babies, and Asian babies sort of are doing the best in their group. And we also have Pacific Islanders and and Alaska Natives, American Indians, but there's like no patients for this group. So yeah, just This is interesting. This is all very preliminary data, but these are also like links to outcomes. And so, you know, if you're like, it's a human milk at discharge by timing of skin to skin. So if you do skin to skin care early, you know, then this is the overall group. Like on the first day, again, it gets up and down here. Maybe first day is not good. If you do it by 2 days, about 90% will still be breast milk feeding at discharge. But if the first skin to skin, you know, happens here 31 days or later, then only like 70% are still doing breast milk feeding at discharge. Similarly, human milk nutrition by oral colostrum, if you do the oral colostrum early, there's a high likelihood of still breast milk feeding at discharge, but the later you do it, it kind of tends to go down. If you never do it, it's below 60%. You know, this is a relationship to similar to instead of breast milk feeding at discharge, this is nosocomial infection. So skin to skin early seems to be relatively stable. If you don't do skin to skin until 15 days or later, much higher risk of nosocomial infection. Now, what's the chicken and the egg here? These are like correlations, right? Like obviously, these babies might have been extremely sick for some reason, and that's why they didn't get to do, or the family didn't get to do skin to skin care, and you know that might be driving the difference here in infection rates. So we've got to be careful about causality, but interesting finding nevertheless. Here's nosocomial infection, oral colostrum. Again, like seems like there's sort of a trend through here. Like the later you do it, the worse the nosocomial infection. And then finally, this is major morbidity, survival without major morbidity. So you'd like and skin to skin. And so survival, again, the earlier you do it is higher. Survival without major morbidity. Oops, sorry. But the later you do it, it kind of drops off. Again, it doesn't mean that skin to skin care is preventing major morbidity and promoting survival. It might be just a matter that these babies are just, you know, very sick. But at least with like the results kind of go in the right direction there. So. And so it provides a little bit of like indirect validity for the value of these measures. All right, so in summary, we don't practice in a social cocoon. There are disparities in NICU care, and we just need to acknowledge them and get over them. We need to address the interpersonal institutional biases and the racism that exists. So family-centered care is really a key pathway to inequity. And in our preliminary data here on skin to skin and oral colostrum, I think are quite promising. So I think I'll just leave it at that. I just wanted to really thank Beate, who's been putting all this together, Ravi Durjati, Malathi, Kimba Padua, Linda Frank at UCSF, who's a nurse researcher, has provided fantastic input as well, Jessica Liu, and everybody on the expert panel who's been working, and especially our parents, Ashley and Lillis. And here's a group of all of the folks at CPQCC, and thank you. Oh, I'm gonna keep this one away. This is
Thanks, Jochen. Thank you. It's a great presentation. Thank you. So we have only 4 minutes left. So I just wanted to end with one question from Dr. Mayers. So you can see it on the chat here, Jochen. So he's thinking, because it's not easy to obtain the data, so do you think there is a way to partner with families, so in collecting, gathering, tracking any of these measures?
Yeah, so we are thinking about reaching out to families. Our maternal side is already doing surveys of families. You know, it's not easy to do. Like we'd have to you know, essentially get the units to participate, to provide some sort of link to in which they could access a survey and then provide us with feedback data. So it's you know, that's a hard thing to do. Like these essentially 2 measures, I think, like since the social worker, I'm not quite sure we'll keep it. these two measures, I think, provide like a good, could provide a good start. I don't think they're terribly difficult to collect, quite honestly. Like the vast majority of our NICUs found them pretty easy to collect. Now, there are some that don't have electronic records, and they need to like find what is the time that this was done, and so it's more difficult. But you know, if we actually were to like sort of standardize these for the entirety of the network, it's pretty simple to add a field to your EHR, you know, to like, when did you give your oral colostrum, and if that's done, then you know, that's like very simple for an abstractor to submit them. So I don't think these are very like, we're very conscientious about making these as simple as possible, because we do realize the pain of data collectors having to like sift through medical records to try to do that. So it's really intentional that it's simple.
Thank you, Jochen. Yeah. So we have 2 minutes left. So I just wanted to end our conference webinar with the next month webinar, just in March. So we will be focusing on our home transition. So Dr. Vincent Smith and Christy Lau will be talking about the National Perinatal Association guidelines about home transition. And I will be talking about our unit, how we use the technology to improve our home transition process. So stay tuned for more information. So you can scan the QR code and provide us your feedback, and we really appreciate, and we review regularly your feedback, and then we are making changes based on your feedback. So just to take a few minutes to provide your feedback about today's conference or what you wanted to see in the future webinars. And the other thing is, if you are planning to attend Graven's conference, Dr. Browne mentioned in her talk, so it's in March, and small group leaders are planning to attend those conference. So please join us in the FCC task force, planning to have a luncheon meeting on Thursday. So we will send out more information. So that's for the Graven's conference. The other thing, small group, if you are part of the small group, and Colby mentioned in the beginning, phase 3 work is implementing and strengthening the Family Centered Care Committee or Family Partnership Council in your unit. So as a part of this, so your small group leader will reach out to you with the future dates and time. So stay tuned for that information too. And thank you everyone for joining, and have a great afternoon. Thank you. See you next webinar. Bye.